Our PICO question is, in patients with continuous telemetry monitoring, how does proper anatomical lead placement compare to improper lead placement in reduction in misdiagnosis and false alarms? We chose this topic due to the inconsistency of lead placement for both 12 lead EKGs and 5 lead telemetry. During our research, there was found to be a notable lack of articles concerning anatomical electrode placement and its relevance. Articles that did have evidence concerning correct lead placement were written in 2014 to 2015, so they are somewhat dated. Several of these articles reference the large-scale study, The Practical Use of the Latest Standards for Electrocardiography, or PULSE, which has examined the way that we use cardiac monitoring, which was completed in 2004. The first article that we looked at was called Cardiac Monitoring and Electrode Placement Revisited. Researchers in this article completed a study monitoring 1,816 patients in 17 different hospitals. In this study, the findings showed that limb electrodes were misplaced 15 to 27% of the time, and chest electrodes were misplaced up to 76% of the time. These were based on variance from the standard precordial electrode positions. The researchers in this study also found that nurses documented heart rhythm changes only 51% of the time, nurses appropriately monitored for ischemia only 41% of the time, and documented the QTC only 20% of the time, which is an important sign for repolarization abnormalities. According to the article Cardiac Monitoring and Electrode Placement Revisited, the right and left arm electrodes should be placed as far from the heart as possible, at least at the infraclavicular fossa. The right and left leg electrode must be placed below the fifth rib to detect inferior wall changes. The chest electrode is crucial for ST segment monitoring and differentiation of wide QRS tachycardias. The chest electrode can be placed at any one of the standard precordial positions depending on the type of monitoring. These positions can be seen in the figure on the next slide.
This figure shows the correct placement for 5-lead telemetry. The RA and LA leads are placed just below the clavicle. In this figure, the C lead, representing what would normally be the brown lead on a 5-lead telemetry, is placed in the fourth intercostal space and can be placed on either the right or left side of the sternum. The RL and LL leads are placed on their appropriate sides below the rib cage. Our second article discusses proper skin preparation and electrode placement and how that can decrease alarms on units that utilize telemetry. In this article, it said that the guidelines for ECG monitoring were developed in 2004, but it's not used everywhere in nursing practice, and so there can be some variations in it from hospital to hospital as well as from unit to unit. This also puts patients at a higher risk of misdiagnosis because of the improper and incorrect lead placement. Poor skin preparation and inaccurate electrode placement can lead to false alarms and increased risk to patients. This can mean the misdiagnosis of arrhythmias, leading to inappropriate treatments such as cardiac catheterizations or electrophysiology testing, which, as we know, are not the least invasive options. And a lot of the time, muscle artifact can be misinterpreted as ventricular tachycardia or other lethal arrhythmias, and it has been shown that patients that this has been happening to have been getting unnecessary devices such as defibrillators. Due to improper lead placement and skin preparation, the study showed that us nurses are responding to telemetry alarms every 2 to 6 minutes, and about 80% of these alarms were due to artifact and not actual arrhythmias. It's estimated that 80 to 99% of these alarms in a critical care setting are false or non-significant, which can lead to misdiagnosis, nursing burnout, and decreased patient satisfaction because of all of the noises on the unit. Also, all of these false alarms have caused 566 deaths, according to the FDA, between 2000 and 2008. Furthermore, this study states that without proper skin preparation and electrode placement, there is an increase in false alarms. However, there are not studies to support this. There's very little research over this topic, but there are multiple studies examining various ways to reduce incidence of nuisance alarms by changing the alarm limits, which we can simply do on the telemetry monitors. This study also talked about the PULSE trial, a 5-year multi-site randomized clinical trial examining implementation of the American Heart Association guidelines. And it reported that although telemetry monitoring is the cornerstone of cardiac units, it is inappropriately used. Elaborating on the PULSE trial, it was a sampling done with patients admitted to a telemetry unit at a VA medical center. They were counted for 24 hours on the admission of 25 different patients. The study was completed in June 2013. This just talks about the sample of the people that were used and the amount of alarms that went off. And with the proper skin preparation and proper electrode lead placement, there was a 44% decrease in alarms.
The PULSE study builds on the evidence that proper skin preparation and electrode placement decreases alarms. Electrocardiographic monitors account for the largest amount of alarms in the hospital, and sentinel events have occurred because of alarm fatigue related to excessive alarms. All staff responsible for applying electrodes to patients should be educated on proper skin preparation and placement of electrodes. In addition, it is important for nurses to question, evaluate, and make changes to current practice to improve patient care. Article 3, Misplaced EKG Electrodes and the Need for Continuing Training. This article discussed themes that often lead to discrepancies in EKG monitoring, such as misplacement of electrodes, anatomical differences, impact on diagnosis and management, and training issues. This article showed that electrode placement can be up to 90% inaccurate without proper training. This can lead to under or overdiagnosis, which can increase morbidity and mortality rates. This can also add a financial burden on the patient and unnecessary treatments such as catheterizations. This article recommends annual hands-on training courses, as well as a standardized, mandatory training package and certification process. For our fourth and final article, we reference St. Luke's centralized telemetry monitoring policy, which pertains to all patients with physiologic monitoring through the centralized telemetry. All dysrhythmias or abnormalities will be communicated to the registered nurse based upon the priority of the abnormality. Communications regarding telemetry monitoring will be a priority for patient safety, for patient and appropriate patient management. The St. Luke's centralized telemetry monitoring policy states that telemetry electrodes should be changed daily. Before electrode placement, hair should be clipped from chest if necessary, and electrode sites should be cleansed with soap and water and dried before electrode placement. Different levels of alarms vary from level 1 red alarms such as VT, asystole, to level 3 green alarms such as low battery and leads off. Telemetry technicians will collaborate with the RN caring for the patient. Alarm levels that deviate from system defaults will be authorized by the RN. Overall, our recommendation is that St. Luke's Health System creates a HealthStream module that educates on anatomically correct lead sticker placement and the importance of changing lead stickers, and that it educates nurses on the importance of documenting rhythm changes when they occur on telemetry. In summary, we did find a clear lack of research on the topic of anatomical lead placement, which was our PICO. However, we hope this presentation will shed light on both the research that needs to occur and the changes that we recommended, with patient care always at the heart of the matter.